a live video playing.
Dada, is the Facebook live visible? তুমি দেখতে পাচ্ছ?
Page na group কোথায় দিয়েছিস?
Both actually.
Both. Okay, I'll just check.
Can people tag us? I can't see anything.
Yep. Just check it.
Yes, I can see. Yes. The video is live.
Is there?
Yeah, if you could kindly tag us, we can actually all get.
Yeah, I'm sharing. Yeah. It's here.
Would you kindly tag sirs and ma'am, if possible?
Yes, I'm tagging everyone. It's here.
Tag all of us present in this meet.
Yes.
Things come through.
Yes, done.
Nothing's come through.
Yeah, I'm done tagging. Are you all getting it?
No.
I shared the link.
Is it on your Facebook page?
Yes, it's on my wall as well. I tagged all of you.
Well, I can't see anything on your wall
Yes, it's here.
other than you performing an operation, which is credible. Isn't going to help the case.
Okay, I got the
Yeah,
link.
I think
I
I
got
got
it,
the link now.
yeah.
Yeah.
Yep. Good to go.
Okay.
Thanks, Banerjee.
Thank you, Vijay.
Yes, and what's just one thing before we begin? Do you have to know what about the YouTube link? Is
It's
it
working. Achut, check it. I just checked it right now. It's working.
all right? So, yes.
Achut, it's working fine, right?
I don't see any.
Yes, sir.
Fortunately, the video is unavailable. 1 minute.
It's still playing.
It's still playing. I can see it.
Yeah.
Don't
Okay.
use the link directly.
Is
go
it
to our
visible
channel.
Is it visible on YouTube directly?
Yeah, I am asking you to open YouTube via your mobile phone and just check it out.
Yeah. Just a second.
Yes,
Yeah,
Deptanuta, while I'm opening it in YouTube, it's not opening.
Don't
No,
use the
Achut,
link.
it's-
Don't use the link. Directly open the channel and
Okay.
share the link from there.
I'll send in a new link. Just a minute.
Yeah. Please send in the new link.
Will you please send the YouTube link?
Yes,
WhatsApp it?
YouTube. It's here.
Achut,
Can you send the YouTube link, please?
Yes, sir.
Achut, the YouTube link is playing perfectly. Okay,
So fine.
Yes, sir.
Fine.
it's playing perfectly.
Please
It's like
send the
playing
YouTube
perfectly.
link.
Send it on the chat. I think
Yeah,
ma'am
thank you.
can access it via chat.
Yeah.
You can
I've sent
just
it.
Okay.
Oh yeah. Okay. So we are on.
you're on.
Yes.
Okay, is it recorded too? Is it
So-
recorded too?
Yes, Krish, it will be recorded. So,
Okay.
so we are here.
Achut,
you can- Yeah. Good evening, everyone. So finally, we are here. I welcome everyone to the international webinar, which is a panel discussion for today on mental health, moral injury, and healthcare challenges during and after COVID-19, and Indo-US-UK perspective. I'm honored to have all of you speakers and moderators are here. Before I hand over it to moderator Sir Dr.Kunal Sarkar, quick list of the speakers. There's Dr.Mridul Banerjee, Dr.William Waugh, Dr.Abhishek, Dr.Kris, Param, Dr.Kaushik, Ghosh, and Dr.Binayak Sinha. And we are also having here Dr. Banerjee, who is the founder of West Bengal Student Medical Cell, and myself, Vijay. So I welcome you all. Dr. Sarkar, sir, it's over to you now.
Vijay, thank you very much. And as we were sitting through for the looking as if the collaboration for the COVID virus is going on, So it was kind of as hectic as that, but you all cracked it in the end, and I'm sure that is the way the virus vaccine is going to go through. So with that note of optimism, I think Bengal Students Medical Cell has really put in a lot of effort. They've put in a lot of hard work. And I think, somewhere very deep thinking has gone behind organizing this webinar, because this puts together a speaker from 3 countries, which is India, UK and USA, which has made a total mess of the COVID control program. So if you had a little bit of southeastern, some members of the Buddhist belt participating, we could have lifted ourselves from the gloom and despondency of failed public health measures to some measure of public health success. I think, but that I'm sure Vijay will consider for part 2 of the webinar. So as the three prominent players of the COVID front, who has been caught well out of their crease and summarily stumped by the wicketkeeper in form of the nature's virus, I think let us start this what promises to be a very, very interesting symposium, webinar, etc. Our team, our plan of things is going to be very simple. We have a lineup of 6 very diverse speakers who's going to pool in their experience, their introspection from their field of work, and along with their speaking and professional skills, I have no doubt at all on their skills of chronology. And as they have been forewarned, somewhere between 4 to 5 minutes, Vijay will be displaying his set of nasty faces, and that will convey to them that the time is about to end. After that, we will take in a round of supplementary comments, because I think it's very natural for the speakers to react to what the others have said, and that should leave us with time for some good participation with the speakers, with the viewers who would have been with us on the live links via YouTube and Facebook. So on that note, I think could I request Mridul Banerjee, Dr. Mridul Banerjee, an alumni of Calcutta National Medical College, is currently a consultant psychiatrist at the Prince Charles Hospital and Royal Glamorgan Hospital. So I think it's always very good, because I spent a good bit of time in the other bit of Wales, which was called North Wales. So I think let us have a South Welsh kickoff to this COVID match. Yes, Dr. Banerjee, it's all yours.
Thank you, Dr. Sarkar, for that very warm welcome. And thank you to all who've taken the time out to join us today. So since you've mentioned the word South Wales, let me say Croeso, which is welcome in Wales, and Pryninda, which is good afternoon. I'm pretty sure I sound gibberish, but I hope the rest of my talk is not going to be gibberish. So because I'm a psychiatrist and I deal with the geriatric population, so over 65, I had been through the thick and thin of this. And as you rightly pointed out, Kunal, that the UK and along with the other countries you mentioned has made a bit of a boo-boo in this, but all is not doom and gloom. And the pandemic has been a significant stressor, in addition to the tremendous impact it has had on our everyday lives, be it in the general public, be it the frontline workers, be it in children. So it's a different age group. Within the time constraints of say 4 or 5 minutes today, I won't be able to go through all of that. I had helpfully prepared some slides, but if you want to put it up, Vijay, or shoot, that's perfectly okay. Sometimes slides help people just to look at it, and they don't have to look at my face or listen to the monotony of my talk, perhaps. But basically, it's the fear of illness, the uncertainty about the future, which can precipitate anxiety and stress-related disorders. One of the main things that one has to understand is stress, anxiety, fear. These are all natural, normal responses. So we don't need to start medicalizing it. However, if it becomes pervasive, if it becomes long-standing, if it's affecting your performance, your day-to-day performance, it is certainly something that you need to be aware of and ask for help, because help is there, help is evidence-based. Now, some of the things, if I can just sort of quickly touch on is that the pandemic has thrown in the uncertainty, the fear and worry about your own health. If you are working, in hospitals, then of course you worry about your health. Then you go back home, and of course there's a stigma around healthcare workers working within, hospital settings or even community settings, as in UK. So this could lead to your feeling extremely anxious. You're noticing a change in your sleep, eating patterns, difficulty in concentrating, and if you've got pre-existing health conditions, be it physical or mental health, that can be exacerbated. So I'm now talking obviously generally in terms of the healthcare workers, but it's got a massive impact on public's health as well. And one of the things that I need to highlight within this time is that if you're noticing all of this, one of the things that you need to understand is you need to communicate your worries. You need to be aware of what's going on. You need to seek help. You need to have a core group of people, be it family or friends, who you can speak to and say, look, I'm really worried. I am getting all these things, and try and see what can happen. The other thing WHO has mentioned is infodemics. Too much information out there, some good, some evil, some fake. Some people just do it for the sake of attention. You need to have switch off times from the screen. You've got to be having, you consume news intentionally. So if you're constantly checking news, if you're constantly checking to see what's the update, and not all updates are doing good, so that could bear on your mind. And one of the long-term sequelae is a prolonged stress reaction, which even can, border into PTSD. So those are areas which I'm more than happy to discuss if people throw questions at me. But one of the things I need to touch on very quickly is about moral distress that some of us, and mainly the frontline workers, have had to face, which is a conflict between, as clinicians, we want to do the best, we want to provide the best of care, but because the pandemic has limited our resources, so like if there is one ventilator, you've got two patients, you've got to go with best interest, you've got to go with best outcome. But it's easy to say, well, the frontline worker or an intensivist makes that choice, but that choice is quite difficult for the person. The person has to go through that, sort of conflict within a moral code that the person has as a medic or even as a nurse, and has to live with that. So moral injury coming from moral distress is something that cannot be, sidelined. It needs to be acknowledged. Managers, hospital seniors need to acknowledge it, and we need to communicate any problems that you have. So that's something, worth bearing in mind when we're dealing with it. And it can happen in the general public as well, from your own fears, from your own worries, and that can make you ruminate about it. So pre-existing conditions like depression, anxiety, OCD, obsessive compulsive disorders, can become quite entrenched, and this is where people need to get in for right help. And can I just stress that it affects everybody and across the strata and any age group. Thank you.
Thank you. That was a very compassionate beginning, and you really underline, you really emphasize the burden of worry in this situation, and the necessity to communicate, and the very important business of us selecting candidates for treatment, given the resource constraints. And probably we can touch on it later sometimes. You keep on hearing, because apart from the initial Italian experience, the northern Italian experience, we hear all these conflicting data about whose healthcare was overwhelmed, to what extent. Was it really an overwhelming experience? Were we overwhelmed, or did we overreact? So which of the two aspects are true? Probably that will come up in the future, but extremely important and very crucial points. Now, with that, I think these are the points in which Dr. William Waugh, who's been a junior doctor, but I think he's not junior anymore, because he's been at the front line of this campaign, and whoever who's been exposed to the front line of this campaign has been matured, the steel has been tempered with the heat of the crisis. And I think, I for one, at probably, William, I'm about a century older than you, and even at this stage of existence, I've not really not enjoyed being thrown at the wolves as far as maintaining circulatory support and other programs as far as this crisis was concerned. So you were at the green shoots end of the spectrum. So William, who's been a junior doctor, who's from a hospital in Kent, was pressed into service. So William, we are ever so keen to listen to your experience.
Well,
the floor is yours, William.
thank you very much, Dr. Sarkar. That was a very generous introduction. I think perhaps that is the best perspective I can offer in this sort of setting, is just what the experience was like for the junior doctors on the front line. And probably building on some of what Dr. Banerjee said, I think we experienced a lot of the same issues that you highlighted there. So, as Dr. Sarkar alluded to, at the time of first peak of COVID, a large number of us were sort of gathered up from our home teams. I myself was working on urology surgery at the time. There were people scattered across the hospital. We were sort of gathered and redeployed into the coronavirus, the COVID hot wards, the areas that were being set aside in anticipation of a high volume of coronavirus and COVID patients. So this was obviously quite a stressful time for all of us. I think we found this experience of being informed that we were going to be the ones on the front line quite stressful, caused a lot of feelings of apprehension in myself and my colleagues, concerns for sort of not only our own well-being of our friends and family and those around us, but also the concerns that were highlighted on the news media at the time, things about whether there was going to be a shortage of PPE, whether hospitals were going to be overwhelmed, all the sort of hysterical media that was being, repeated on every possible platform at the time. So myself and a handful of other juniors were redeployed onto one of the COVID AMUs, the acute medical units that were being sort of frantically cleared of patients in anticipation of a large number of COVID admissions. And I think our experience starting on that ward was extremely challenging. It was sort of a real baptism of fire. We had a very, very high turnover of patients initially. It was a 24-bed ward, and I would say approximately every 8 hours we had an entirely new set of 24 patients. So 24 patients would come in, be triaged and clerked, and then sent across the hospital, and a new lot would come in, which was very difficult and very stressful for all of us, because we arrive in the morning. By the time we finish the ward round, half the patients are new. We have to start again. It led to some challenges in management that I think none of us were quite anticipating, but I think they proved to be very educational for us all. I think in addition to the sort of just the cognitive challenges and the sort of anticipated day-to-day challenges of dealing with a high volume of patients, dealing with patients who are very unwell with COVID, and dealing with such a high turnover, there were also challenges we probably didn't anticipate that reared their sort of ugly heads in various different ways for different people. So just sort of from a brief survey of my fellow juniors at the time, I think we all experienced a great deal of physical and mental fatigue. All leave, all study days, all days off essentially were cancelled. We were working very hard, very long shifts, and it was physically quite demanding, but also mentally draining. It was a very high stress environment, and high stress day after day after day takes its toll. And I think this also contributed to a high level of emotional fatigue for all of us. The majority of us were isolated from our friends and family, our sort of normal coping support systems. Lots of us were worried for especially elderly relatives, friends, family, worried for our colleagues, and also worried for ourselves, because at that time there was a lot of misinformation. No one quite knew, but everyone had a story of a supposedly young and healthy person who'd been struck down. So I think at that time there was a lot of uncertainty, and one of probably the biggest and most taxing things that no one was anticipating was questioning our own practice. Not really being certain what we were supposed to be doing. At the time, guidelines were changing on a fairly regular basis. There was a lot of very interesting research happening, but it meant that from one day to the next, almost, the patient could be a candidate for some new treatment that was being discussed or hypothesized, and then the next day things had changed. And it did lead to a degree of thinking, am I doing the best for my patients? Could I be doing more? Am I doing better? Am I doing worse? You know, which is challenging in itself. You join the profession because you want to help people and you want to do the best for your patients, and it's challenging to keep sort of doubting yourself like that. So I think that's something that we found as a team was very important, and I think we need to take forward as a team, or learning from this, was that just being honest with ourselves and being honest with each other about the challenges we were facing, becoming our own sort of support system, because obviously it was a very unique experience, and we were sort of, you know, the only ones who'd gone through it together. We were the ones who understood it. So having that, I think I'm being given the single for time, but having that experience certainly brought us together, and I think we all learned a great deal. Thank you very much.
Sorry, I think I'm on the mute. So thanks a lot, for the very touching, for the very personal note that you struck in recalling the experience you all have been through. I think I'm very curious to ask you a few things. I'm just trying to recall my days as the chap on the ground, the senior house officer, and everything, and how we would have faced up to a challenge like this. So we'll come back to you. I, for one, very curious to know a few things. I think Abhishek, Dr. Abhishek Ray, will probably give us some supplementation of the UK experience, because Abhishek, after graduating from Tripura Medical College, is now currently a registrar in acute medicine in Epsom and St. Heliers NHS Trust, England. Abhishek, it's your 5 minutes now.
Okay. Hello to all the panel members, and thanks for inviting me over. I would like to start by saying that recalling the definition of health by the WHO, which says that health is a state of complete physical, mental, and social well-being, and not merely an absence of disease or infirmity. And probably this definition couldn't have been better portrayed at a time than the COVID-19 that we faced for a couple of months. It was about our medical professionals are involved in fighting the unseen, but most often the known. But this time it was fighting the unseen as well as the unknown. I cannot say that I was fortunate, because obviously this situation was nothing to be fortunate about, but I happened to be on the ground at a time when COVID-19 was at its peak in the United Kingdom, and our trust was hit really hard, as like any other trusts in the UK. Now, most of the challenges that we faced initially was we did not know what was happening, because this particular disease had implications on a multisystemic mode. It involved the respiratory, and it involved the gastrointestinal system, the neurological system, the cardiovascular system, everything. And most often than not, when we were thinking of something and treating, and we suddenly faced a completely new challenge as to how this has happened, and we did not know. And at one point of time, it was about going through all available research works and studies and trying to do things at the best interest of the patient, without even knowing that whether that would work or not. One of the other challenges being as a senior registrar was to guide my junior ones, my SHOs, my foundation year ones, my foundation year twos, as to what they need to do, because they will escalate whenever they are facing an uncertainty. And you have to show your firm and stern faith there, showing that you are in control of the situation, whereas at certain points you feel that probably the situation is basically something which you don't have an answer to. The other thing was, as Dr. Waugh very rightly mentioned, that a lot of junior doctors were redeployed, and that too from various specialties like dermatology, ophthalmology, just to help the staffing on ground. And again, that was a different challenge to make them do stuff without getting impatient with them, and at the same time making them feel really well supported. Also, I believe that the system in the UK is such that a lot of patients, they live in nursing homes and residential homes away from the families. And this particular disease, COVID-19, has got an incubation period of 5 to 14 days, and where it has the potential to involve an entire institution and involve all the elderly patients, and which we know that they are the most vulnerable patients, and one of the most vulnerable categories of patients. So we faced a lot of influx in terms of patients, and also the fact that I'm speaking of the interval between January and say, for example, April or May, where the incidences of respiratory tract infection is quite high in the UK. So almost all the respiratory tract infections which could have been usually been treated at home were coming in at the suspicion of COVID. So this was one of the biggest challenges that we faced. Trying to give the treatment to the people without making them wait, and also allotting a bed in a challenge setup, because obviously the system, no matter how good the trust worked, was unable to sort of cope up with the influx of the patients. Also the fact that in terms of dealing with the emotional thing of seeing patients pass away in front of you, young patients pass away in front of you, which they are not expected. The patients sometimes holding your hands and saying, I want to see my son and daughter, I want to see my partner before I go. But I know I don't have much time left. But you cannot let them do that, because our hospital adopted a policy of not letting in family members during this time. So it was a bit of an emotional struggle on our side to deal with everything. Also the fact that there are people who had respiratory issues and were not able to comply with wearing the masks all the time. So in terms of getting the people wearing the PPE was also a big challenge in those category of people. And as Dr. Mridul and Dr. Waugh rightly mentioned, that in terms of getting the people to comply, people, and also handling the emotional stuff as well as the physical infirmity was quite important for the overall well-being of the person. The media also on some channels sort of overplayed the issue, were giving a lot of messages which people were thinking. There were people who came in overdosing with a lot of over-the-counter medications like hydroxychloroquine. So dealing with those side effects was really important, and I believe these are the challenges that we faced in London. Thank you.
Abhishek, that was a very honest account of some of the challenges which I think which were so real and which were so critical, especially the challenges of witnessing young mortality. And all this business, this is what we are seeing now, has completely redefined the way we communicate the prognosis, that we communicate the clinical progress to patients' relatives. So it's probably a kind of an old game that is being played on a new pitch. And so much is said and so much is yet changed in front of our eyes. Very well spoken, Abhishek. Now, after Abhishek, we cross over the Atlantic, and we are in the company of Dr.Kris, Dr. Parameswaran, who currently is in the University of Berkeley and University of Washington, and his field, which will add to a lot of what we discussed today, is spiritual and social psychology. Dr. Ramakrishnan.
Microphone. Mute.
He's on mute.
Oh, sorry. Again, so restart. So thanks for your invitation, Bajik, and thanks for your introduction. I'm a psychiatrist, and currently I'm working on a project on spiritual psychiatry, a fellowship. We are trying to build a fellowship program. I'm in a PhD program now, a candidate. It's a program between UC Berkeley and Stanford. Okay, I'll start from where Mridul left. That is a moral injury. For me, the most important place where I can start is from Beck's triad of depression, where we talk about a negative self image, a punitive surroundings, and a bleak future. As a psychiatrist, we always try to see how best we can help the patient see positives in himself or in his surroundings or in the future. So that's what we are going to do now. What has come out? What has COVID brought the best in us? What is it going to do for our future? Is what is most important. I know I am not a person who want to live in an imaginary world. The real world is there's a lot of suffering and pain. But what's important for me to know is that only when we emerge out of a painful situation successfully, then we have grown spiritually. There's a great saying which says that without crucifixion, there's no resurrection. We can see that in the stories of every great person of the world. Rama, for example, now the environment in India is Rama, Jai Shri Ram environment. So he had to go through that lot of struggle in his exile, and through that struggle, when he emerged to be the divine, a God that we all worship. Even when we worship, we want as an evidence-based spiritual care provider. What we do is what do we learn from people who are out there as spiritual masters? Anyways, I'll come back to that in a minute. So I want to see like what COVID has brought to us. At a personal level, we can see examples of how we all have grown more charitable, more positive. We have been helping one another. We have been altruistic. We have been compassionate. For example, our profession. I have seen through political stuff around our profession. As a student, I have gone into hartals and strikes for pay hikes in our as a student. But now we are the most important profession in the world. We are on the front line. So appreciating a charitable profession is itself a positive, very positive stuff that we are seeing. In an interpersonal, that's all that already have moved to the interpersonal. Distancing, but the slogans that I'm trying to see. Maintaining distance, but not disconnection is a slogan. So in that is a slogan that be connected. In interpersonal connectedness is a spirituality, and there we would emerge successfully even through toughness and pain and loss. I know there are a couple of Britishers here. So the British Prime Minister had said, post-COVID, the business is not going to be as usual. So what did the third angle of the triad? So we have to see like what is COVID going to do for the future of the world. We all talk about this particular 2020 as a 0 year. I strongly believe that. I somehow started to believe that in India there's a philosophy of time as a yuga, cycles of spiritual cycles, not a linear but a cyclical span of time. So this could be a good yuga change where we are moving in a direction where interconnectedness, empathy, compassion it will be more important. So these are things that I would like to say that which I can see as a positive triad instead of Beck's depression triad. And when it comes to me as a question answer hour, I would be able to see speak for myself. What do we do to prepare ourselves to the future? That's it for now.
Thanks very much. Thanks very much, Dr. Ramakrishnan. Correctly said that India is in the temple building mode now, having messed up both the pandemic and the economy. And the most evident working spirit amongst Indians has been the 60% alcohol that is used in the hand sanitizer. So, apart from that, and probably, I'm just saying, I'm little bit of a funny mood this evening, that to see every possible profession has led India's pandemic campaign. Led by a pediatrician, a cardiologist, a biomedical person, etc. Anyone but an epidemiologist. And the only one who has not emerged in the leadership is a guru, right? So I think I don't put it beyond the current establishment. Might see a touch of saffron in the ICMR hierarchy in the very near future. Time will tell, we cease to surprise us. So, but I will deal, on a more serious note, the very important points that you made for an attitudinal transition, from one kind of attitudinal transition that this will probably. Now, whether it is imbibed in us or whether it is enforced in us is a separate matter. But I think that transition that you have referred to is of great significance. Now that brings us to Dr. Binayak Sinha. Dr. Binayak Sinha is one of the most acclaimed and followed clinicians, endocrinologists in our city. And Binayak, being an ex-alumni of National Medical College, he is not just a clinician, he is very academically involved. And we are all ears to listen from Binayak this evening. Binayak, please.
Mute.
You are muted, Binayak.
Kunal, thank you so much for your very kind words of introduction. I intend to take a slightly divergent view and not talk so much about this. We will probably be talking a little bit about the moral degradation of the masses that have come about. And I will tell you a story to start the deliberation. Now, I have known this boy called Rupam since he was 11 when he presented to me with type 1 diabetes. And now 17 years down the line, 28 years of age, he has already become an engineer, holds a very good job. And a few weeks or maybe a month ago, he developed a little bit of a sore throat and a runny nose. He went to see his doctor, who advised a test for COVID. The COVID test came back as positive. He was well in himself, and he returned to his apartment complex in I would say, a Tony neighborhood of Kolkata to find his neighbors of so many years, who he had helped out on very, very many occasions, up in arms about his illness. The secretary ordered him to leave immediately and not infect others with quote-unquote this disgusting disease. And even when the doctor came in and said that you cannot do something like that, and he is a very good candidate for isolation at home, he was called a Nongra Badmash, which for people who do not understand the local lingo means a dirty scoundrel. And he was forced to take him to a corporate hospital. Corporate hospitals being famous for overcharging and making life hell for the patients by making money out of them. And this gentleman, being in the corporate hospital, this chap, he kept on saying that, please keep me in hospital. Because he did not want to get back home and go through the same rigmarole of being ostracized and being stigmatized by his entire group of neighbors in his entire apartment complex. And he basically ended up staying in the corporate hospital for about 14 or 18 days till his test came back as negative. We know for a fact that a lot of people actually have tests which keep on being positive in spite of the fact that they are not infectious anymore. So he had to foot the bill, which was a pretty large amount of money. And he still says, when he came to meet me, that this was much better, staying in the hospital and footing the bill, rather than the stigmatization and ostracization that I had to face from my neighbors, people who I had helped, people who have seen me since childhood. And the fact is, Rubom is not a unique character. This is something that is happening all over India, particularly in Kolkata, where people are being turned out, are being prevented from entering their own houses by unsympathetic landlords and neighbors. But what people are failing to see is that though COVID is infectious, about 95% of people will not even realize they've had an infection. They'll get better or have a mild flu-like illness. In fact, I'll quote you a little bit of statistic which I looked up just a little while ago. The crude fatality rate for India last year at this point of time was 7.23. And this year, I don't know whether it will surprise you or not, it is 7.19, which basically translates that last year per day in India, 27,000 people died. And this year, about 26,500 people have died every week. So are we really looking at this contagion or this infectious epidemic where we can not only take steps to look after the patients? We are in a situation where we have to face this evil epidemic of ostracization, which I think has been brought about largely by the hyperbolic media, which has continued to highlight only the issues regarding the number of deaths and increasing number of incidents, and saying today we crossed 60,000, tomorrow we crossed 65,000. So, this is where I think our moral compass has been completely destroyed and degraded. This is where I think we have lost the battle. Stigmatization has been there in society since in ancient times. We heard of, even in the time of Jesus Christ, we had these stories of lepers being asked to leave the community. But in this day and age, somehow, in spite of improvements in so many social, so many economic and scientific facts, the thing that certain base instincts, that certain base human instincts have not improved at all. And this is what I think is the huge epidemic which we have been hit by. And this is what has caused us a tremendous amount of mental hurt and moral decay. And this is what I think we need to look at in a lot of detail, that we need to make sure that this does not get repeated in the future. COVID will go. It will definitely go. I strike a positive note saying that we are now peaking, and after every peak, there will come a fall. But I think we should really take this in our stride and try and find out how we can get rid of this kind of baser instincts which the human mind is engulfed by. Thank you.
Binayak, you really spoke for a lot of us. You really spoke from your heart. And some of the things that you touched upon, I'm sure we will dwell on this in the discussion round. And it caught my eyes also. I mentioned it in one of the media discussions a few days back, that COVID, the last 5.5 months of COVID paranoia in India would have saved lives. And there we go. And it determines, probably it should now guide some of the approaches. Very well, very sort of, very stark, very important reminder. You've underlined so many important points. We would come to Dr. Ghosh, and when anybody has this very tricky job of introducing Kaushik, I think it is always easier to mention a list of things he does not do rather than a list of things he does very well. And Kaushik, whom we've known for a long time to be an excellent surgeon, an orthopedic specialist, an actor, a photographer, a poet, and if I was to continue the list, then I think your time on YouTube would have expired. But Kaushik, after all, remains a very vibrant mind, and his contributions in the public domain as a doctor, a speaker, a performer, has always enriched what we've set out to do. So on that note, Kaushik, please follow Binayak and give us your insights into the COVID in India, in Calcutta at this point of time.
Thank you, Kunalda. Can you hear me, everybody?
We do.
Yeah. Okay. So thank you, Kunalda. As usual, you love me so much. The introduction was more of a hyperbole. I'm quite sure I am not justified in taking all that praise. There's very little time that we have to talk about it. And, while so many speakers were speaking and there are different dimensions of what people are saying from across the Atlantic, in UK and in Calcutta from Binayak, there were a lot of things which were floating through my mind. Most of it is based on personal experience. Now, see, since there were two people who were from the field of psychiatry out here, and we're talking mental health, on the ground reality is, every day, and I'm one of the few clinicians in Calcutta who have kept his private clinic open from the 24th of March. So I've never stopped working. So I've faced this question day in and day out from patients and the grocer and the fishmonger. How long is this going to last? And I don't have an answer. Sometimes I say November 2021, sometimes say 2020. And then they ask me, isn't there going to be a vaccine? I said, look, the media is giving you a false impression of a vaccine which has come along. Accept it, that vaccine has to be efficacious, it has to be safe, it has to be cheap, it has to be distributed. So it's at a very, very least, it will take you 1 year. Now, coming to the first portion of mental health, one of the most interesting things that a lady asked me, she was over 70, is that when there are extremes of age, there is an interesting aspect of COVID in this situation. One is that she said, I'm like a dog. A dog year is equivalent to 7 human years. She said, for a young man or a middle-aged man, 1 year of staying in lockdown or not being able to interact may be easy. But for an elderly person, staying out of touch with a near and dear one, 6 months is a huge amount of time, because for her, time has contracted. The same thing for a child who's not going to school at a primary level. For him or her, getting out of school, keeping out of school for 6 months is a huge amount of, that is time expansion. Now, that part of mental health is usually something we are not thinking about now. Perhaps the mental health professionals are. But since the topic here says during and after COVID, we really have no idea what is going to happen after COVID. Are these elderly people, are these children ever going to cope with this PTSD, as Mridul pointed out? Because it is a trauma. COVID is a trauma. Now, coming to moral injury, I was actually tempted to take off from the question of sanitizer that Kunal pointed out. You see, if I may paraphrase Charles Dickens, we live in the worst of times and the best of times. It obviously brings out the best in us and the worst in us. Now, as Param pointed out, there is a lot of people who are doing a lot of things. There is a lot of charitable work that is going on. But there is also our government in India, which is actually charging 18% GST, which is tax on the sale of sanitizers. It is also our government which is spending crores and crores of rupees on a parliament complex which is to come up, and a Ram Mandir. Across the seas, there is another gentleman who is actually having a Republican convention where people are dying. Now, this is not empathy. Now, where is this connected to moral injury? What do we teach our children? Our children are asking us, what is this concept of migrant laborers who are not being able to go back home? Why is the situation such that they're dying on the streets, either of starvation? And we are understanding that the basic concept of moral inequity comes from two things: starvation and medical care. Now, COVID is made us face a situation where the stark realities of inequity have come true. I was just quoting before this session started, off the cuff, that there was an interview on BBC Hard Talk with the WHO head of South African continent, and she actually admitted that if and when the vaccine comes, the last people in the world who will get the vaccine are those poor people in Ghana or Somalia or Congo. Now, that is the hard reality. So here, as a thinking individual, as a philosophical individual, you would tend to think, aren't those inequities really destroying the fabric of humanity? Now, I can go on about that because there's lack of time. I would like to mention one very interesting aspect which I was working on in the morning. Healthcare challenges during and after COVID. Both during and after COVID. I'm not going to talk about the challenges being faced in combating COVID because there are a lot of experts on that. I'm not qualified. But what I'm right now working on is a vaccine protocol for routine immunization in the third world during COVID. The statistics are alarming. Between February 2020 and April 2020, 1.4 million children less were inoculated for pentavalent vaccine, for measles, for routine immunization in India. The comparative analysis between April 2019 and April 2020 is there is 60% less routine immunization. And this is what I'm working on. So this is a huge, huge thing. It is during COVID, routine immunization has stopped. And if this routine immunization does not resume, there is going to be a huge bleak future for children all across the third world and Africa and India in the days to come. Thank you very much.
Very, very, very well spoken, Kaushik. It is not just the elegance of your style, but also the strength of the points, the contents you have made out is absolutely, absolutely crucial and very germane to the issue that we discussed this evening. Now, let us go round and do a few minutes of discussion on your secondary inputs. Can I ask our participants who are our panelists who are from the domain of psychology? We have Dr.Mridul, we have Dr. Ramakrishnan. Binayak pointed out, the harsh reality that we have faced stigmatization, this discrimination with doctors, with patients, probably a little bit more in the beginning. It's not as if it's completely disappeared right now. So will one of you just dwell on this point? That has it been your experience, say in UK or USA as well, has instances of this happened? Or is this a very Asian or a very Indian selfishness? Or has this been manifest in your part of the world as well? Why doesn't Dr. Mridul tell us about this?
Well, I've been, as an Indian and living in Britain, I have been keeping up with what's happening in India. So I think it's India, we see a little bit more acute response in people. So we've seen violence, increased violence, including xenophobia. And I think the concept of xenophobia, secondary to COVID, where people have been targeting Chinese people or people looking like Chinese, across the globe. And in terms of stigmatization, which I also touched on, we had heard initially in the months of March or April that there have been doctors who've been living in rented accommodation who've been targeted. But I have to say that the heartening news was that the government looked into it immediately and proper measures were put in where landlords were given warnings that that's not going to happen. And some sort of a threshold where people have harbored not good intentions about people coming back from hospitals, but I have to say that is much more intensified in Southeast Asian countries than what would be expected in UK, Europe, and I think USA as well.
Yeah, I think somewhere the stress for survival, the stress for individual survival, and seeing oneself through to the next morning is definitely a little bit more acute in more hard-pressed economies. Dr. Ramakrishnan, whilst we deal in the mental health front, you had given us a very important sort of spectrum of the positivity of the attitudinal changes, but somewhere are you a little bit apprehensive of the fact that all this business of the hesitancy, because it's got to be a very compelling reason for next time two human beings come within 6 feet of one another for something which is not compellingly unromantic. It has to be a very strong reason to do that. So how do you feel that this kind of movement and proximate restrictions will influence human behavior? Are we going to remain the same species that we were? You are muted. Yes.
Well, this is what I feel is the challenge that we all need to take up. We have to emerge out of the ashes, as the saying goes. When we talk of a positive future, we don't forget the reality. The reality is painful. Dr. Binayak brought a case study. If we go with case studies, we learn a lot. So that case study that he said in his personal clinical experience, the stigma towards towards people who are suffering, the ostracizing society, a broken compass in the world. We need now I'm wearing my hat as a PhD scholar. So first we need to identify the problem. So that's the problem there. A negative world, a punitive society, a low self-esteem person, or somebody who is wary of everything, sees everything through a negative lens. So that's the problem. And what can be a good solution? No one can make another person behave in a good way. The attitudinal change should come from within. How does that come from within? Is through education. So that brings me to the place where I'm working. Spirituality, all that we are talking about when we are talking about a broken moral compass, or ostracizing society, or as you said, Indian selfishness. There's nothing called as Indian selfishness or American selfishness. Everything that's evil is there in every human being around the world, and everything that's positive and spiritual and empathic and compassion is there in every human person. We all have seen the entire the Black Lives Matter story coming from USA, being such a wealthy country, advanced nation, the topmost on the list of nations. If we have such negative things, it's obvious that other places also we will see. So wealth and prosperity, it will not change our attitude to being compassionate or empathic and positive.
Thanks, Dr. Time permitting, we'll come back on that aspect.
Yes. So the education, I'll stop there.
On the aspect of education, I think you really opened up a new dimension. Now, to Dr. Waugh and Dr. Ray, both of you shared very honestly your experience in UK. Can I start with William? William, recalling, because I think your battlefront had heated up somewhere in March and April, a few months ahead of ours. So when people like yourselves were drafted onto active service, so as to say, how would you recall that? What was the orientation? What was the training? So I've got a question about the initial training, mental training, medical training to equip you in terms of time, and how did you do it? And the second thing is that for the hospitals in UK who were suddenly facing deluge in the first stages, clinically, since UK is so systematically compartmentalized, so clinically who was leading the battle? Was it critical care? Was it clinical medicine? Was it A&E? So who was pressed into the clinical visible leadership? These are the two questions I have. So William, if you would tell us, how were you oriented before being told that you are marching on to the battlefield right now?
Certainly. Well, I think obviously in hindsight it's easy to criticize and to say that people could have done things differently, and I'm not going to do that. I will say that our orientation, our education was minimal. We were sort of informed of what would happen. We were given some brief induction, and then it was sort of all hands to the pump and find your feet as you land. I think that was not done. There was not a sort of malicious intent or anything along those lines, but it was just a sort of a struggle. There were so many people to kind of reorganize and reorient that they gave us they were forced to give us the minimum and anticipate that we would learn as we went along, which I think we did. I think it was challenging for everyone because things were just changing at a very high rate. So I suppose even if they had given us orientation and education, they would have then had to repeat it in a week's time because things would have changed. So perhaps the view that was taken was just they will have to learn as they go along, as everyone else has. I think that's probably a not unreasonable view to take at the time.
Abhishek, could you, in continuing to what Williams just told us, that two questions that, how were you clinically organized at this stage? And the second question, I think you raised a very, very good point, a very important point about the communication, in these times of stress, informing patients, relatives, seeing the people who are critically sick, probably not with too much time in hand. So over the passing months, did it change? Did it evolve? Or did it remain very difficult and awkward as it was in the beginning?
Right. So in terms of the orientation, I do remember that our trust did actually organize sessions on non-invasive ventilation and very important sessions on donning and doffing of PPE, because one step of wrong donning and doffing of PPE can actually lead to the complete PPE being contaminated by the virus, and that defeats the entire purpose of wearing that and going to face the patient. So I agree with William that in the hindsight, it's probably very easy to say that this could have been done, this was not done well, but judging by how very suddenly the situation came in, just which can be mentioned as a blitzkrieg, which Adolf Hitler did on Poland when the Second World War started, it could not have been done in a more, it could have been done in a better way, but practically there was no time. People had to go in, senior people like the consultants, the registrars like me, the more senior SHOs, they had to take more responsibility in guiding the redeployed juniors to our ward, making them feel supported, and also to make sure that mentally they are not sort of scared about the fact that they will be exposed to the virus and probably taking them back to the families.
Just a quick question to both of you, since both of you were there in south of England, if I'm not mistaken, where the intensity of the problem was at its highest. Did you actually visibly see the healthcare capacity getting overwhelmed, that your respective hospitals couldn't really take in any more patients? Abhishek, why don't you answer it first? Did you visibly experience it? Because I was probably a little bit more ignorant than what I am today. So in the end of February, I was in London, staying just across the road from the Wembley Arena. I think that was later on turned into one of the Nightingale hospitals, but that wasn't used much. And in that hotel I was staying in, I was surrounded by 300 young Chinese people, and we used to have a whale of a time at the breakfast, completely unaware what was happening in their part of the world. But anyway, made great friends. But so a lot of good capacity was built up, was not used. So quickly, in a minute, did you actually experience it, that the hospital was chock-a-block and couldn't take in any more patients?
No, fortunately enough for the St. Heliers Hospital, I work in the St. Heliers site of our trust, and fortunately enough, we did not have to deal with a situation where we had to refuse them and say that, well, we don't have capacity for you. I cannot comment on the critical care unit because that's a completely different unit altogether.
Okay. Thanks, Abhishek. William, quickly from you, what about...
I think thanks to the foresight of our medical director team, we didn't reach the stage where we actually breached capacity. Unfortunately, sacrifices have been made to enable that, such as cancelling elective procedures and things to that effect. Yes.
Well, thanks very much to both of our youngsters sharing the clinical UK experience with us. Binayak, you've been so insightful in what you've stated. I think I'll have a common question, and I would want both Binayak and Kaushik to answer in the end. That from your experience, both of you, Kaushik made very important points about the overall immunization. And basically, I think the common tone in both of you was that this COVID has colored so much of our spectrum that probably, even though healthcare capacity has not been breached, but probably our minds have been oversaturated. We have been imprisoned in this COVID world. So, as an experienced clinician amongst the two of you, how do you see? I mean, how do we sensitize? I think it's more easier sensitizing people than sensitizing administration. That how do you emerge from this COVID-dominated dialogue that has, that has been absolutely prevalent for almost 6 months, because we've really elasticated. Most of Europe has been through this turmoil for 3.5 months. I'm sure it will stretch beyond 6 months as far as we are concerned. So, Binayak, you first. How do you think we emerge from this?
So, I would like to tell you, Kunal, from a very small personal experience point of view. So we have a group of friends who regularly interact on WhatsApp. It's a WhatsApp group. So we have kind of made the rule that we cannot make any posting related to COVID in that group. It has to be something which is not related to COVID. And I think in a very small kind of way, I'm not trying to live in a fool's paradise and think that this is not happening. I am fully aware that this is happening. I am a physician who looks after patients with COVID. I don't want to bring my work home, neither physically nor mentally. I don't want to bring the virus back. And I also do not want any kind of clutter that comes with the entire concept, this entire paradigm of COVID coming into my mind all the time. I take a very positive view of it, contrary to what a lot of people have said. I think India has fared quite well with COVID, and it's well on the verge of defeating COVID. And I also feel that we should take a conscious effort to try and avoid discussion on COVID, particularly on social media, and the print media has to take some responsibility and come up with some kind of positive news every day when it publishes its newspapers. Thank you, Kunal.
Kaushik, I think for you, I think I'll just specify it even more, that you see, whenever, we are now facing, probably our friends in UK and USA won't share it with us, we are now facing across the country the realities of normalization, the realities of opening up transport, suburban, urban communication, intercity transport, for people who are living to get to their livelihood, that kind of a situation. So, Kaushik, do you think that our thinkers, our policymakers will muster enough? It's a combination of courage and wisdom, which I think time and again there's been scarcity of. So, how would you, if you had a chance, how would you guide that process?
I don't want to be a spoilsport, but Vinayak is from a school and from college, and I've always had this lovely habit of contradicting him. But now here are the facts. I think the discussion between Kunal, you and Parameshwaran was something to do with how you change. Now, let's face this, we are not going to come out unscathed from this pandemic. I'll give you a simple statistic. In 1983, WHO declared another disease a pandemic. It was AIDS, the HIV infection. The moment that happened, in the next 10 years, every year, the profit margin of Durex, which makes what, increased by 65%. We have never come out of it. We are talking about the COVID pandemic. AIDS, we have lost 25 million people. We have 65 million victims. Now we're facing a disease, come what may. We cannot suffer from an ostrich syndrome. We cannot dig our faces in the sand and think it's just going to go away. It's not going to go away. When last month I told some of my colleagues who were in the practice field in Calcutta that you're going to have a 65,000 per day count increase by the end of August, they had laughed at me. They have also laughed at me because every day I use 2 PPE kits, 2 sets of gloves, 2 sets of bags, because just like William said out there, Abhishek said out there, I cannot use the same PPE kit. So I use it in one chamber, dispose of it biologically, go to another place and use it. It seems there should be a balance between optimism and pessimism. We've got to live with this. We've got to get used to conversing about COVID. We have to get used to masks, just like AIDS forced us to wear a certain other thing. So that is the situation now, the ground reality. Now that does not mean we're going to be pessimistic. Things are going to be good. I mean, there's going to be a time, there's going to plateau, there's going to be a vaccine. Again, there are these fake news which comes in, if you look up the net, you see it's very, very difficult to make a RNA virus vaccine. Most of the vaccines which have been prevalent have been DNA vaccines. And we haven't been able to manufacture a vaccine against AIDS in 22 years or more. So let's have some kind of paradigm shift. You should not be either optimistic or pessimistic. You have to get used to the new normal. That is the term that is being used. You have to get used to wearing a mask. You have to get used to washing your hands.
Again, I think a closing question to both you and Binayak is: both of you are so grounded clinically. Do you get the feeling from the ground that time has come to normalize our things like transport, the rest of hospital services, etc., or would you wait longer? Binayak first, quickly.
No, not yet. I would go straight ahead and tell you that no, not yet. Maybe we need to have a little bit more time. But I will give you one interesting statistic about healthcare workers being infected. This is, of course, American data. Of all the healthcare workers infected, only 0.14% could be actually traced back to being infected on public transport. So this kind of puts into perspective the importance of public transport and the infectiousness of COVID-19. So, but still, we are peaking now, so I would delay it probably by a month.
Kaushik, would you agree with that?
I would love to have it delayed indefinitely, but it doesn't make sense because someday, whether it's after a month, after 6 weeks, you will have to open up public transport. It is better to sort of create a situation where you have precautionary things in place. Instead of having 2 buses, have 10 buses. Instead of having a certain local train be packed like sardines with 75 people, have 25 people. I think that's the only way forward. But that will require a lot of help from the government. It would require a lot of cooperation from the common man, because the common man is not being told what are the exact time it is. So we are having a lot of discussions, but there have been no protocols which were distributed in the public. I'll end by saying there is only one state in this country of India which had created a small little 25-page leaflet distributed in Hindi, Malayali, English and other South Indian regional languages in the state of Kerala, where it was specifically mentioned that the common man's understanding, very simple terms, what is it you have to do, what is it you ought not to, and that is why even if temporarily they have been able to control it, even if they've had a spike now, Kerala is still managing the COVID to such an extent that they are very good, well known all across the world. Thank you, Kunal.
Very true. I think that was absolutely a very learning, a very learning and absorbing experience, because and all of you, we remain in the debt of all the 6 speakers who've really been so honest, so insightful in the way you have spoken. Now, Bojik or your friends, do you have a quick couple of questions that we can take, because
yes, I have one question. William mentioned one point about the mental and emotional impact on the patients and patient relatives. For example, he mentioned the one patient says, I want to see my partner, I want to see my husband, but it's not possible in this COVID background. So I want to ask all the doctors who are out there practicing, how are you coping up with the empathetical challenges? Since we have talked over and over again about empathy, in these times of COVID, where we can't interact properly, we are maintaining distance, how are you overcoming the empathetical challenges faced during clinical practice?
Do you want anyone to answer?
I think he addressed the question to
William, yeah.
So yeah, I think
it's for everyone. Like Dr. Ghosh can answer as well.
No, I think
don't ask everyone to answer. Because
I think let William answer first.
So yeah, I think it was Dr. Ray that made the very good point about patients wanting to see their family, not being able to see their family, and that was certainly something we experienced as well. That was I think a nationwide initiative to stop families entering hospital and try and reduce spread that way. I think it was very challenging, because you do certainly really feel for these poor patients who can't see their family, especially the older patients who may have difficulties communicating or may have cognitive difficulties, who are really, really struggling without having family members there to support them. I think it was a real challenge for all of us, and it did certainly take its emotional toll on us as well. I'm sure Dr. Ray would agree.
I would just intervene at that point. Take the question to Mridul. Mridul, at any point has the mental health or the psychiatric services been asked for to participate in these countering these kind of stresses? Have any of you or your colleagues had any experience with this?
Thanks, Kunal. I think it's a very, very important point, and yes, we have been asked to provide advice. So the way things have been is that, as William here has said, and Abhishek as well, is that because we had stringent visiting rules, we've not been able to allow people, even when there's end of life, we've not been able to allow in the beginning months for families to come and be with them. Yes, there have been FaceTimes and all the rest of it, but a face-to-face contact, especially when somebody's dying, has been extremely important, and that hasn't happened.
Mridul, thanks. Kaushik has a point.
I think Parameshwaran would agree. Sometimes empathy requires a stick policy also. So, Boyjok addressed the question at clinical practice at a very basic level. There are people who come into my chamber with a patient and then suddenly put down the mask, and I have to admonish them, why are you putting down the mask? And then one thing that really works in Calcutta right now for the last 1 month is, if you get COVID and you get admitted, the minimum amount that you require to even come out of the disease is 3 lakhs. I don't know how much that is in British currency or US currency, but there's a huge amount of money for a common Indian out here. Immediately, the person puts up the mask. Now that's a very simple way of explaining to this person that you have to wear the mask. Okay.
Kaushik, don't rub it in. We are already facing a lot of flack with private hospital expenses.
No, I was not talking about the.
yes, but that is a pertinent point. Any other questions that you have gathered?
Deptanuda, is there any other question?
Yes. So this I would like to address it to Mridul ma'am and Parameshwaran sir. We as junior doctors, as residents, are handling patients who are symptomatic as well as asymptomatic contacts of tested positive patients on a regular basis, and as a practical part of our professional lives, we are seeing on a daily basis many of us residents, consultants, we too are testing positive. We are seeing the person who is working with us today is going into isolation the next day. So any advice from your end, how young doctors, junior doctors, as well as of all age groups could counsel themselves, or what should be the mantra for all us doctors while we are fighting this COVID pandemic, so that although we see all this around us,
we get the question. Devtonu, yes, you are sounding like a doctor from Maharashtra, because whoever is not testing positive in Maharashtra, Shiv Sena is denying them the Maharashtrian identity. The last Maharashtrian to be infected was Amitabh Bachchan. Like in 1918, it ended with Gandhi getting infected in Sabarmati. So anyway, I don't think Gandhi had an RT-PCR at that stage, but I don't know how they diagnosed him, but they did. But fair enough. So yeah, Shiv Sena is very rigid that, unless you show antibodies and you have had an RT-PCR positive, they doubt whether you've been in the state.
Kunal, there's the other way. The other side of the story is, yes, I have had the misfortune of losing a very close near and dear one to COVID 3-4 days ago. Okay. Now, in spite of the death certificate uploaded to the computers of the West Bengal government, the government kept on calling the wife of this gentleman for 4 times per day, inquiring, how is your husband? Ultimately, on the 4th day, this lady said, my husband has passed away. It has been uploaded in a computer. So here's the other way around. You are anonymous. You have passed away. Your body has been decimated. It has been taken care of. It's been incinerated. But the statistics will show that instead of 24 people dying per day in a city like Calcutta, there are only 3. That is the way statistics are being hidden, and that's the ground reality. When we are talking about combating COVID, I think first thing that you should do is be transparent. Let's face it, we have a problem.
Data manipulation and data deficiency has been a problem, and you can never fault the Bengali for being optimistic. You see. Anyway, so even in the dark days. So would Dr. Ramakrishnan would like to comment on the question that Devtonu just raised?
So I think you have to unmute yourself.
Yeah, that's a very good question, Devtanu. It's what brings into my mind is how, as junior doctors, I was, or we are all, kind of nonchalant or try to be less careful when we enter into more dangerous situations. And it's to be fair, it's attitudinal too. It's not just whether you're a junior or a senior. The numerous very, very senior physicians with tens and decades of experience, they have fallen prey. They have fallen victim to this COVID. So where this thinking takes me is, just as Kaushik doctor was telling us, the patient would come into your room and he would immediately remove the face mask when you're very close in proximity with your doctor. What tells me of that behavior is the feeling that there's something disconnecting between you and the other person when you put a mask.
True.
So basically, it's a good problem actually. There is a good attitude problem, but attitudinal mistake is there is a spirit there which wants to connect with the other person, but the physicality is very important too. The spirit cannot live with the physicality.
I think we'll take a remark from Mridul. Yes.
Mridul, yeah.
Thank you, Kunal. I'd like to just sort of quickly to say, I know it may sound a bit of a doom and gloom. Please remember, COVID is a marathon. It's not a sprint. So take time. And one of the things that I often say to the junior doctors is, because our junior doctors have been deployed, and you have to understand, in mental health, we are a bit removed from acute medicine, acute surgery, but our junior doctors have been redeployed, and now they're back to us. But what we have said is that do what you feel you can do within your limitations. If you feel you're working outside your limitations, raise your hand and say, sorry, I don't think that will be in the best interest of the patient, and learn to relax. You're not God. You're also learning, and believe me, as consultants, we are learning as well. Nobody knows. Even WHO is changing their regulations and rules. But learn to relax, learn to look after yourself. If you are being given back-to-back shifts, put up your hand and say, I need to relax. And form a core group of people. As Vinayak pointed out, I would second that. Please do not talk of COVID all the time. There's a plethora of fake information, memes, WhatsApp logos and stuff like that. Get into anything, singing, dancing, but try and do things which you enjoy. And I can tell you, we're all doing good things.
Yeah, taking a cue from you, Kunal, about the optimistic Bangali, I would like to remind Dr. Kaushik Ghosh about his doom and gloom story of statistics being flawed. That, in this time and age of social media and mobile phone cameras, when people have an idea of what games Dr. Ghosh plays with his dog, do you think death could really have been hidden? And I think the answer you will find, Dr. Kaushik Ghosh, is no.
I end that, with permission of Kunalda, with just one simple favorite line of Dylan Thomas, and death shall have no dominion.
Quite true, quite true. I think, it's been a fascinating discussion. So yes. We gave ourselves an hour. And Achyut, did you?
Yes, one question.
Yes.
May I have the permission?
Please. Yeah.
At the very onset, like being the junior most person here, I would like to apologize if my question isn't as well constructed as my seniors. But this question was mainly framed by me, drawing points from questions from my friends, relatives, and others who have talked over the last near about half a year spending inside my house. So like we are nearing almost half a year under quarantine, and most people have been asking about a general constellation of symptoms, primarily involving insomnia, loss of appetite, and an acute loss of concentration in their work. Be that seniors who are working from home, or us in medical school who are currently trying to study but failing. Like people who are normally capable of drawing 18 hours a day, consistent study and work, are barely managing 2 or 3. Is it possible to shed any light on this as to why it is happening, and is there any way out? Because after half a year of
we get your point. We get your point, Achyut. I think it's definitely got to do with the acute disruption about what we knew to be everyday life, because we are very well programmed animals. So in such a way, when the program gets rebooted, I think we are taking our time. How would Mridul advise Achyut that is there a way out of this, or this is inevitable?
Thank you, Kunal. It's called an acute stress reaction, and it's a very normal phenomena. There's nothing to worry about that it's going to become persistent at this stage. But as I've mentioned just before, is that you need to recognize it, and you need to be able to look after yourself. So getting good rest, getting good sleep, but more importantly is communicating about these feelings. Now, I don't know whether your housemates have been able to do that with you, but not necessarily with medics. I'm pretty sure they've got, uncles, aunts, kaku, jetimas, neighbors that you can talk to, and it's not necessarily always, hesitating. Because just talking about these things doesn't make you have a mental illness. It makes you a normal human being, the normal response. So just talk and, look after your body, look after yourself. But if you're recognizing that it's becoming to the point where you're not able to get out of it, and you're ruminating constantly.
It's a vicious cycle that's going on. Insomnia, and we are trying to rest, and more insomnia, loss of appetite. It's a vicious cycle that's going on, and you're not able to break out of it.
If it's persistent, seeking psychological help, talking therapy, even the most basic of its kind, is what I would strongly suggest, and it doesn't make the person any less. So it is not seen to be a weakness. It is actually a normal response. But get help if you feel it's not going to go away. I would rather have talking therapy advice rather than go into medication like sleeping pills and antidepressants and other things, because that has other repercussions as well.
That's very true. And I hope I'm not being facetious when I say that. But somebody told me they did seek a psychologist's help and found out that the psychologist was more stressed than the patient. Right.
I can see that for myself.
Yeah. So it depends, which way the gradient, the stress, the quantum of stress will ultimately flow. We've got to live with it. So I think we've had a fantastic discussion. Thanks to all of you. And we've learned a lot. Bojik, I think you and your friends have worked very hard. So for the closing comments, I hand it over to you. I think your hard work is paid off. Well done, right?
All right. Yes. Thank you so much, sir. Thanks to all the speakers and moderators, sir. It was an honor to have you all on board. And we just have a small token of appreciation. So I'll send a small certificate to everyone through the email.
We would like to thank the poster designing wing of West Bengal Students Medical Cell for designing this small token of appreciation for the doennes we've had with us today. Thank you, sir, ma'am. It was a wonderful experience, learning experience for us youngsters, and we would really like to have such educative sessions in the future as well. Thank you.
Thank you all.
I'd just like to say that thanks to Bojik and his organization for organizing this, because it's lovely talking to people from different fields, from different parts of the world, and it was a huge learning experience. And Kunal, thank you so much for moderating it.
Thank you.
It's been a pleasure. It's been a pleasure. All of you keep well, stay safe.
Stay safe, stay well. Thank you all.
Thank you.
Bye-bye. Bye.